Our next presentation for this morning is an update on cervical screening and contraception by Dr. Georgiana Tang. Dr. Tang was born in Hong Kong. She graduated from the Uni of New South Wales in 1992 and trained at St George Hospital. Dr. Tang commenced her specialisation in obstetrics and gynaecology at Liverpool Hospital, and in 2004 she completed a Masters of Reproductive Medicine from the University of Western Sydney. Dr. Tang has practiced reproductive medicine for the last 15 years, and her practice includes all aspects of management of fertility, from evaluation to treatment, as well as general gynaecology and laparoscopic surgery. She has been the co-founder of a number of IVF units. She was staff specialist at Liverpool Hospital and a lecturer for both UNSW and Western Sydney University for 5 years, and is currently a private gynaecology and fertility specialist in the Liverpool area. Dr. Tang is well known for her personalised and friendly approach with patients, and she prides herself on providing the highest standard of care and strives to achieve the best outcomes for her patients. Please welcome Dr. Tang.
Thank you very much for inviting me on a Sunday morning to talk about this topic. You have to let me draw my blood pressure. I almost missed the turn and I was going to go into M7. Luckily there was no cars, no reverse all the way back to turn back in, so here I am. Now the organisers are, in my opinion, a bit ambitious to give me this topic, because basically there are two topics, sort of not related, but it has massive information. So I have squeezed in 68 slides within an hour, so hopefully you guys got enough brain power in your brain to get take all this in. I've condensed the talk. I'll summarize it. So I cut down all the sort of primary studies and evidence, etc. I'll just go to tell you sort of what you need to know for the two topics. Now, the National Cervical Screening Program renewal is due to start from 1st of December this year. So it is a major change for everybody. Majority of the contents of this talk on the cervical screening program originates from the Cancer Screening and Prevention Forum that was held recently. And you need to check out the website, the bottom link, which is from the Cancer Council. And this website is enormous and it's got good information. So if at any point you're a little bit lost about what you need to do, go on this website. It's amazing. Now, let's start with the history of Pap smear, because that's what we've been used to doing over the past 16 years in terms of screening. Historically, is a Greek doctor, Dr. George Papanicolaou, in 1928 that developed Pap smear. 1943, it was acknowledged that it's useful in the diagnosis of uterine cancer by vaginal smears. 1982, they demonstrated that HPV is the cause of cervical cancer. In 2008, Dr. Halson got the Nobel Prize for HPV, I was going to say discovery, but demonstrating that HPV is the cause of cervical cancer. Ian Fraser developed the HPV vaccine. And then in Australia, 2007 to 13, that's when the government rolled out the national HPV vaccination program. Now, since the development of cervical screening, Australia has been highly successful in terms of cervical cancer prevention. If you look at the incidence of cancer, the female cancer in Australia in 2017, these numbers are expressed in the age standardized rate of cancer in 100,000 women. So you can see that the leading one's breast cancer, and then it's the bowel cancer. Cervical cancer is actually ranked 14, which is excellent, and thanks to the cervical screening program over the past 60 years. So cervical screening program has successfully dropped the incidence and the death arising from cervical cancer. So you can see the graphs of the historically since the screening for cervical cancer. However, look at the bottom line. 80% of cervical cancer actually come from the never screened or the underscreened women. So therefore, as far as cancer prevention is concerned, these are the people that we need to work on. And therefore, the development and the renewal of the cervical screening program, hoping to reduce this further. Now, currently, this is what we've been using. We've been used to over the past 60 years. So we're doing pap smear, which is cytology. Women are being screened every 2 years, and the recommended age for pap smear screening is between the age of 18 to 69. And women are sent a reminder when they're due for the pap smear. So what's new to come? You no longer write pap smears on your form. You write cervical screening test, CST. Basically, it is a test of the oncogenic HPV testing. We'll talk about HPV in a second. It's going to be 5 yearly. I can tell you, a lot of women's going to get scared and worried. You say, well, Dr. Tang, are you sure it's safe to do every 5 years? We've been doing it every 2 years. Even people get nervous about screening every 2 years. They request yearly these days. So we need to have enough data to support that 5 yearly screening is safe, and we have. The screening age is going to start from the age 25. Now, again, a lot of people are going to get anxious about that. And this change of the starting age is going to cause a bit of confusion for people who are already in the screening program, and you tell them that they no longer need screening. So I'm going to give you some information about, what happened to the transitional cases and things like that. Women are going to be sent invitations and reminders. And of course, this is something new, which is the self-collection. A lot of people hear that and say, what? You self-collect your sample? Are you sure that's helpful? I'll talk about that in a second. Now, why have we decided to change the cervical screening program? Because there has been new knowledge and development of new knowledge on the development of cervical cancer. There's new evidence on cervical cancer prevention and screening. There are new technology of the liquid-based cytology testing, there are computer-assisted images analysis, and of course, it's the HPV testing. I mentioned that from 2007 onwards, there's been national HPV vaccination program of the girls, and then from 2013 is the vaccination for the girls and the boys as well. So with the vaccination program, it has been shown to further decrease the incidence of cervical cancer. By the way, I can see you guys writing notes and taking pictures. You guys are welcome to get a copy of my presentation from PHN if you want. So you can sort of concentrate on listening and things like that if you want to. Now, cervical screening and sensitivity and specificity comparing pap smear and HPV typing. So you need to know that pap smear is a cytology testing. It is highly specific, but it only has a moderate sensitivity, meaning that 15% of cases will give you a false negative, meaning that a normal pap smear, actually 15% they're actually people with disease that's not picked up by the pap smear. Compared to HPV testing, it has better sensitivity. It has a higher negative predictive value, meaning that if the test comes back HPV negative, it is highly likely that it is correct, and therefore this is the basis of being able to stretch out the interval of testing from 2 years to 5 years. It has a more reliable clinical performance because cytology is the cytologist looking at the cells, commenting on the appearance, etc. This is going to be automated. It's going to be a computer-assisted analysis, and as far as QC program, etc., it's going to be more reliable. Also, it has greater sensitivity for detection of glandular cancer. You can see that most cervical cancers are squamous in origin, but HPV typing testing, detecting high-risk HPV is going to be helpful towards predicting glandular cancer as well. Now, HPV has been the center of attention for the past many years, and if you look at the structure of the picture of the HPV, it's quite amazingly beautiful. Let's talk about HPV, which is the center of the attention of this cervical program. Now, HPV is the baddie, we think, because only the high-risk ones anyway, we think. It causes 5% of all cancer worldwide. From first year of starting sexual activity, 30% of people will come in contact with the HPV. Within 3 years of sexual contact, 48% of people would have come in contact with the HPV. And we believe that 80 to 90% of people will have been exposed to the HPV at some stage in their sexual history. There's been more than 100 types of HPV identified, and they're the 4 major groups with the various subtypes and can cause various health problems. Now, as far as the anal genital cancer risk of HPV is concerned, there are more than 40 types. They're transmitted via skin-to-skin contact or mucosal-to-mucosal contact. And the mean duration of infection will last for about 8 to 10 months. And typically, say, if you've got an HPV infection, the symptoms will be cervicitis usually, and they typically report sort of watery discharge or minor sort of pink discharge, etc. But sometimes it can be totally asymptomatic. Now, good news is most infection of HPV will be cleared by the immune system within 1 to 2 years. Now, the age is very important. If the person is young, the likelihood for the individual to clear the infection is actually very high. Now, of course, the high-risk HPV are at the center of attention as far as vaccination is and the oncogenic testing is concerned. So the meanies are the 16 and the 18. But of course, your report's going to report high-risk HPV of the non-16, 18 type, and these are the serotypes that they would mention and that they will look for to report it as a high-risk HPV. Now, the implications of detecting 16 and 18 compared to the non-16, 18 is actually slightly different. And I'll give you the flow chart of what to do depending on what type of HPV in a second. Now, the high-risk HPV is responsible for 99% of cervical cancer, and majority of cases, I'm talking about more than 50% of cases, are related to 16. So 16 is the meanie. But about 20 to 30% are from 18. So therefore, the vaccine has been targeting 16 and 18. Of course, you are all aware of the vaccination, the various types of different brands or different types covering various numbers. Of course, HPV is responsible for the other cancers as well. Now, what's the natural history of HPV infection? We know that more than 95% of cases will have clearance, but it is the persistence of HPV infection and expression of HPV that cause the trouble in terms of cancer changes. Now, you can see that with a normal cervix, it will take a while for the body to clear the HPV infection, and therefore, when there's infection, as far as inducing cell changes on the cervix, there's a process of progression and regression as time goes by. Now, quite often I've got GPs calling up my rooms to say, I want to make an urgent appointment for my patient to see Dr. Tang tomorrow or today because her pap smear is CIN3. I can reassure you that as I understand the anxiety arising from patient and you want to help, I totally appreciate that. But as far as you reassuring the patient, you can reassure the patient that for a high-grade lesion to progress to cancer, it really will take to 5 to 10. For the HPV infection to cause high-grade lesion is in the order of 5 to 10 years. And you can see in that sort of timeline, that's why the 5-year interval program is okay. Now, we know that for only 5% of CIN2 and up to 30% of CIN3 will turn to cancer. So even though you've got a high-grade lesion, a lot of them actually don't turn into cancer. But of course, we usually will treat this high-grade lesion in case they do. But as far as patient information and reassurance is concerned, saying that don't worry, I understand you've got high grade, because most patients, when you tell them they've got abnormal pap smear, the first thing they come into their mind is I've got cancer straight away, I want to get treatment tomorrow, sort of thing. So it is good to give them information based on good evidence to tell them, okay, this is the natural history and this is what you need to do. Now, and we know that only less than 2% of infection actually lead to cancer, and the period that from changes to leading to cancer is in the order of 15 years. And there's a lot of evidence in the past, and over the past 15, 20 years to show that there is plenty of time for us to screen, look for them, treat them to reduce the cancer risk. Now, so how are we as doctors and government and health department, how are we going to tackle this HPV infection? Well, there are two forms of strategies. One is primary prevention, which is by vaccinating. And the secondary prevention is to screen and treat those people who have abnormal results and send them for treatment. Now, adenocarcinoma is the interesting area that come to light as far as the benefit of oncogenic HPV testing. And we know that 78% of cervical adenocarcinoma are actually related to high-risk HPV 16 and 18. Now, just be aware that glandular and squamous lesions sometimes can coexist. And with testing of the HPV, it gives us greater potential for disease detection and prevention with the HPV testing. Now, as far as vaccination is concerned, we're all aware of the Gardasil, which is a quadrivalent. So it covers for 4 types. You can see 16 and 18 are there, and 6 and 11 are the causes of genital warts, for example. And the TGA approval for Gardasil are for this particular age group. And you've got Cervarix, which only cover for 16 and 18, which are commercially available and you can give them. And currently, the Cervarix and Gardasil are the 3 doses regimen. Now, to come is going to be Gardasil 9, which is under development, is probably not going to be in full progress in terms of in use until later on. I'll talk about that a little bit later. And it basically covers for 9 subtypes of the HPV. Just remember that the older the patient, the benefit of the vaccine will decrease, and the more partners the patient has, the lower chance, the lower benefit of the vaccination for her. Just remember that even if young people have been exposed to some serotypes of HPV at a young age, their natural immunity can drop with time, and therefore vaccination actually can boost up their immunity as well. So it's definitely no harm to give HPV vaccination despite an early onset of sexual activity. Now, HPV testing is the nucleic acid testing, and it is collected in the liquid-based cytology, like a thin prep vial. So normal pap smears, you can throw away all your slides and your pap smear holders, etc., but it's still collected in the same way. So as far as the patient is concerned, it's business as usual. It does involve a speculum. It does involve collecting cells from the endocervix, and instead of putting it on the slide, you put it in the thin prep. Now, there has been some sort of technical difficulties when some form of lubricants are used at the collection of your liquid-based cytology sample. Now, just remember, if you get the commercial lab-provided speculum, they're actually pre-lubricated. So you can actually just wet it with water and should provide enough lubrication for most cases. If you need to put lubricant, put a bit of the water-based, like KY jelly type of lubricant on the outside of the speculum, trying to avoid getting the lubricant in the sample, because it does clog the pathology's machines of the thin prep preparation, leading to unsatisfactory results. So this is something to bear in mind. Now, HPV testing is definitely more sensitive than cytology, and it leads to early detection of high-grade lesions, and it can prevent more cervical cancer and adenocarcinoma. And if there's a negative HPV detection, women say for 5 years. Let's talk about the age of onset for screening. So we have changed it from 18 to 25, and the exit age is now 70 to 74. Why do we decide to increase the entry age? Because there's low incidence of cervical cancer in the under 25-year-old group. And with the implementation of the HPV vaccination program, we are yet to see that the incidence of cervical cancer for young people is going to decline further. And over the past 25 years, looking at the systematic reviews of cases and studies, has shown that that during early screening under 25 has no impact of the incidence of cervical cancer in the under 25-year-olds. And there's no evidence of screening effectiveness from other countries for screening age under 25 as well. So therefore, it is perfectly to leave until the age of 25 to start screening them. When the older age group, for the 70 to 75-year-old ladies, they will be asked to do an exit HPV typing, and if they're negative, they can leave the program. Now, intervals of every 5 years, because everyone's used to doing it every 2 years. So there's been pooled data on invasive cervical cancer outcome from 4 European trials of more than 176,000 women. And at longer intervals, HPV typing has been shown to be more superior and greater detection compared to cytology. So during 5 years is definitely safe by doing HPV typing over the 2-yearly pap smear screening. So I mentioned that on the request form, you're going to put CST, which is cervical screening test. And basically, it's the testing of the HPV oncogenic subtypes. And they will do a liquid-based thin prep if the HPV detection is abnormal. So therefore, your report, when you get your CST report coming back, is going to be under these 4 categories. So the lab will actually give you list a recommendation, will give you the result and list you the recommendation. So it will either say at unsatisfactory, low risk, intermediate risk, and high risk. What did we do with the unsatisfactory results? Unsatisfactory result can be due to insufficient material. For me, for collection, you know how you've got the blue handle brush, and then there is an additional cyto brush, which would look like a bottle brush as well. And I actually routinely use both brushes to collect samples, especially the difficult ones with the smaller os. When you have to go a little bit deeper, I find that that's more helpful than just using the blue handle brush. Just remember, HPV PCR testing, it can be inhibited by a presence of excessive mucus or blood or inflammatory exudate. If you get an unsatisfactory result, we will recommend you to do a repeat sample in 6 to 12 weeks' time. Which people will get low risk if they're HPV, high risk HPV not detected? So we're just giving you evidence just now to say that 5-year screening is adequate. And if patients get worried and ask you, say, oh, can I still do it in 2 years, please? And you just tell them that there have been very good evidence to suggest that HPV typing is more sensitive, more accurate, and you tell them it is a far more superior and accurate test for prediction of cancer testing. Most patients are actually happy with that. If they want to do it before the 5 years, they need to know that their testing will not be covered, and it does attract cost.
Do you know what that cost is?
About $100 for HPV typing, and then of course the thin prep may be will be extra as well. But the question is not doing the aim, though, is to have active, good communication explanation to the patient to reassure them. When you tell them this is a better and more accurate test, most of them will be happy with it.
Can you tell us, if you have, say, an 18-year-old who's already screening and had a previous abnormality, are they eligible to have it, or do we wait till 25?
We've got a whole full page of flowchart for that scenario. We'll talk about that later on, yeah? So when you've got cases like this with various past history, etc., it does get very confusing, but there are a lot of flowcharts there to help you to decide. So it depends on the possible low grade or low grade, what the HPV typing is, whether it's high risk, whether it's non-16, 18, and it depends on whether the screening interval, whether they're more than 2 years, less than 2 years, they overdue, no overdue, the approach is totally different. I'll go back to this, I'll get back to that in a second. So the immediate risk are the non-16, 18 with normal liquid-based cytology. I will recommend HPV testing in 12 months. Now, it is not single HPV infection that put them at risk of cervical cancer changes. It is the persistence of HPV that potentially increase the risk. So therefore, repeating will help us to detect the persistent cases. Now, if the HPV repeat in 12 months' time is not detected, then they can do their CST testing in 5 years' time. If HPV is detected is on your second repeat HPV, they will automatically do a liquid-based cytology for you, and irrespective of your the liquid-based cytology, when you score 2 positive high-risk HPV, that equates a referral for colposcopy. Now, the high-risk group are the people that we want to identify. So the report will say HPV 16-18 detected, and they will also attach, because there's an automatic liquid-based cytology result provided as well. And so the 16-18 is straightforward, they are high-risk ones. Or they're the non-HPV, HPV non-16-18, but their liquid-based cytology show possible high-grade or high-grade lesions. Both scenarios, you refer them for colposcopy. So this is a flow chart which I think a lot of pathology providers have already printed their own flow chart that may have distributed to your rooms already, and these are easily accessible from the website from Cancer Council if you're interested. But basically, patient results are stratified into various risk categories, and like I said, the low risk, intermediate risk, they are follow-up surveillance. High risk, you refer them to colposcopy. Let's talk about the self-collection because this is an arm that's relatively new to the program. So these are aiming at targeting people who never get screened. So it may be Aboriginal background, maybe at the low socio-economic class, or if they're the really young people, or people are just totally scared about speculum examination, or they've got the fear of any vaginal procedure. So it's not meant to be a home test like the bowel screening testing. So these people are still encouraged. So if they happen to turn up to the clinic to do something else, and you ask them, have your CST testing? Say, oh, never been screened. And if they decline the vaginal collection for HPV typing, alternatively, we can collect a vaginal swab, a dry swab, and you actually request, put on the request form differently. It's not a CST, this is for testing HPV. We believe that this is still better than doing nothing as far as the people who refuse screening is concerned. So, yeah?
What kind of swab stick are we using?
There will be the dry swab, so it will be a normal plain swab, but will be provided, we'll have a kit provided, so there will be more information rolling out before this, as far as December is concerned. So this is, I'm not sure if you guys been exposed to talk already, but there's a series of education for the health professionals, for the gynecologists, for example. You guys are getting first or second talk on this at the ONG. The gynecologists, we're getting our talk next month on this new cervical program. So don't feel feeling behind that, okay, but it's December, what do? I don't know what form, I don't know what collections and things like that. It's all coming. It's all coming. So these are the group of women that we want to target to increase the screening rate. Now, of course, there's going to be special circumstances that makes the cervical screening a little bit trickier than your general population. So the pregnant women, basically you screen them the same as if they're not pregnant. The only minor difference is you probably don't want to stick the endocervical brush too far into the cervical canal. And if they're almost on the edge of screening, you can, if they're almost due, then you can do it after the baby. That's fine, provided they have previous normal screening. But otherwise, you screen them the same as if they're non-pregnant. Now, in the early sexual activity or victims of sexual abuse, we should do a single HPV testing before the age of 25. And then if this HPV testing is negative, then they will be due for their routine screening starting from the age of 25. Of course, the immunosuppressed, you probably need to screen them more. And if women present you with symptoms suggestive of cervical cancer, please actually request, this is not screening anymore, you detect or suspect that there's disease, then we should need to ask for co-testing of HPV liquid-based cytology, and you also refer them for colposcopy. Now, this is a confusing area. During the transition, we've got someone in the old program, getting the new program. How do we tell the patients, or what should we do? So, if they are under the age of 25, because the reason why 23 is because 23 they've been asked to come back in 25, so it's okay. So if someone's 22, so in 2 years' time when they do for the next screening, they're only 24, they're not 25 yet. So these people are advised that they are okay not to test until they turn 25. Just remember that I told you that cervical cancer risk in the under 25-year-olds is low. You just tell the patients that evidence suggests that the risk of cancer, incidence of cancer is very low. It's safe to leave until screening at the age of 25. Now, so if people are already in the program, they fall into the age group, you screen them as usual when they're due, which is the 2 years. For example, if they are 25 and they're due for pap smear in 2 years' time, you will do your CST when they are 27 in 2 years' time. Because they're in the old system, they're not in the new system yet. If they are overdue for pap smear for under 2 years and they're under 25, Pap test register will send them an overdue reminder. If they're overdue for more than 2 years, then more than 30, they will be sent by Pap test register for a invite to screen, and also will be offered self-collect because they will obviously if they're overdue for 2 years, they're not keen to do it. Of course, you should still do them, but if they don't want to do the speculum pap collection, they will be offered self-collection as an alternative. I already mentioned that the 70 to 74-year-old will be invited with the exit screening test. If they're HPV negative, they can exit the program. Now, back to this doctor's question about existing abnormalities. So this recommendation is for those people who've got existing abnormal pap smear. So we've got existing abnormal results. They will be tested as scheduled, originally planned for them. If they've got low-grade abnormalities in the past, when they're due for screening, we test them for HPV. If they're HPV high-risk negative, they're okay to go on the 5-yearly because it's the persistent HPV that causes problem, remember. So if they have cleared their HPV infection, even though they've got a history of abnormal pap smear, the negative high-risk HPV, you can screen them in 5 years' time. Remember, even high-risk HPV to abnormal cells is 5 to 10 years, and even high-grade lesions go to cancer is 15, 20 years. So to screen in 5 years is perfectly safe to do. If they got abnormal low-grade before the HPV detected, they will automatically do a thin prep on them, and they'll be referred for colposcopy. The treated high-grade lesions in the past, HPV testing is routinely required for tests of cure, meaning that we need to follow up these people for 2 years to make sure that they have 2 negative HPV screening and they've got 2 normal cervical screening. If in that scenario, that means this person already have their high-grade lesion treated, they are no longer showing persistent HPV, then you will continue to screen them every 2 years. What about the AIS, the adenocarcinoma in situ? They are the precancer. If they have been treated, you will need to do the HPV screening with cytology yearly, indefinitely. Now, I've attached a number of flow charts, and because the various scenario, it can be complex. Therefore, I've attached these to this talk, but I'm not going to go through the exact details due to time constraints. But it will be pretty self-explanatory when you look at them. And this slide may be a little bit blurry, so if you want to go to the council website as well, Cancer Council websites on this, and it is very clear. They've got about 10 flowcharts about this. So this one's about transition. Next one's about hysterectomized patients. What do you do? So it depends on the reason for the hysterectomy. Are they done for benign lesions? Are they done for abnormal pap smear lesions? Are they done for cancer? And the recommendations are totally different in the different groups. So you just need to go look at the flow chart and you know exactly what to do. The immunosuppressed people, you need to be screen them more so. And people with abnormal vaginal bleeding, postcoital bleeding, so these are the various things you need to do. These are the pathway for self-collection. And basically, again, you try to detect who's HPV negative, the positive and the negative ones. And basically, if they're high risk 16, 18, you refer them to colposcopy. That's very straightforward. And if they are negative or low risk, rescreening 5. But if they come back abnormal, you actually offer the CST testing for them. So I've just given you about 20 slides about the new changes with massive information and massive changes. We need to implement and do something totally different from what we've been used to do over the past 10, 20 years. So what's coming is that the MBS item number is going to change, and there is no longer a pap smear item number under Medicare. And if women choose to do them more frequently, they need to know that the government's not covering for that. And not covering not because government's cost cut or whatever, it's because there is no need to do it. There's going to be a national cancer screening registry. And this is going to combine with, at the moment, there are the national bowel cancer screening. So that's going to be combined. Cancer screenings are going to have a national cancer screening registry to follow up. There's going to be extensive lab accreditation and reporting, and the lab's got their own accreditation program for QC, for reporting. For standardization, and each lab needs to go through at least 20,000 cases of HPV testing in order they can be accredited as a provider for HPV testing. So you can see that the smaller group with less experience with a smaller program may be phased out as far as the National Screening for Cervical Cancer program is concerned, but we suspect that the smaller lab may then start to liaise with other smaller labs and start to coagulate into sort of larger group. But that's for the pathology people to work out. As far as you're concerned, then you will know which labs are eligible as provider for CST testing. There's going to be extensive QC programs for monitoring for standards, and even colposcopists, certified colposcopists will need to report results. We'll have to have our accreditation program provided, and there's going to be feedback to the colposcopies as far as a QC is concerned. So this program is rather extensive. It actually induced a lot of widespread changes across the industry, starting from patient to GPs to specialists is concerned. Now, the mention about the Gardasil 9, which is a new vaccine, is going to roll out later on. It's going to cover the 9. So it's the 9-valent vaccines cover 9 subtypes of the high-risk HPV. And you'd be surprised to see that it's going to be a 2-dose regime instead of 3 as well. So that's going to be interesting. And the earlier you vaccinate them, the bigger the benefit overall. The last point of therapeutic vaccines, there's been a lot of work sort of prepared on the therapeutic vaccines. So what are they? At the moment, when they've got abnormal lesions, that we refer them to specialists and they get ablative therapy, diathermy, LETs, corn biopsy to get rid of them. And scientists are developing therapeutic vaccines at the moment in terms of instead of surgery. There could be potential vaccination that may help with the regression of the high-grade lesion. So we'll keep your eyes open for all these new developments in the future. So it's going to be extremely confusing. The simple ones are easy to deal with, but I suppose when you've got the tricky transition and special cases, it can get potentially confusing for the patient and the doctor as well. So keep calm and keep an open mind of the changes. There are enormous amount of information available for everyone to assist you to go through this transition ourselves and also to the patients. How are we going with time? Yes, go on. Yes, 16, 18 plus 7 others. Harris. So the 9 vaccine cover for the 9 types of HPV.
I have 3 questions.
Yes.
Number one, it might be, number one, we can say according, number one, you said here, if the screening pap smear shows that is HPV type 9, approved that it is positive for Q-test, it is eligible for vaccine. Is that funded by the government?
Yes, but that's not current at the moment. They're developing that. So when it is out, there will be information available, but that's to come. That's I'm just casting into the future that this is to come. But this is not available at the moment. Not available at the moment. They're developing that.
I have another 2 questions. Maybe a little bit away from the new arrangement.
Yeah.
If your patient came to tell you I always do my pap smear, always normal. Suddenly last pap smear, it shows human papillomavirus
Yes.
plus sense3. When did I catch that? Especially, I'm now having a new partner for 2 years. So the question, her question would be, is that a sexually transmitted disease? Do you think my new husband is in affair? Why all other previous pap smear were normal and suddenly I get sense3?
Okay. What was the first question again? Sorry, there were 5, that's why I lost the first one.
You answered the first question. This is the second. I haven't asked about the third yet.
Oh. From memory, what you're asking is how can someone get abnormal pap smear despite normal testing? So it depends on the collection technique, assuming that's about the accuracy of the collection. So not due respect of the person doing it, but sometimes if you don't sample the right area, then it can be negative. It can be a collection. Previous collection missing any potential abnormalities in the past.
When you say not sampling the proper area, you mean when it comes not into cervical cell?
Correct, because the last test, the traditional test is your pap smear cytology. So therefore, those people, I'm sure you've all gone through in the past, when you put a speculum, you can't really see the cervix. And they're so deep, and it's a technically difficult in collection sometimes.
It was in the cervical cells.
Yes.
Clear.
Yes.
In the old
then it's fine. No, I'm just purely looking at the possibilities of why it is not showing. So it can be a collection issue.
Doing pap smear, we know that if the cervical cell is not present, it means it's not tested at all yet.
That's fine.
But I'm talking if the endocervical cells are normal,
yes,
then all the previous tests, and this is the first test after 2 years from the previous one, sudden onset of HPV positive and sense3 at the same time, and she has a new partner.
I got it. So the first question, the first answer is what I've done. The second answer to your question is just remember the natural history, my slide on natural history of HPV infection. So even though you've got infection, there's regression and progression. And sometimes the HPV can stay dormant in your system, which are showing as the HPV effect on your cytology. So she could have had HPV infection in the past, but not showing evidence of HPV infection in the cytology. So as far as when someone's positive, so as far as timing of contact of HPV cannot be determined by cytology or HPV testing. So as far as timing is concerned, I know we probably in the similar scenario and someone come back with the chlamydial antibodies, which is not specific, which is not the infection, but you need to understand that what the test is testing for. So when your cytology is not testing exactly for HPV infection, therefore it didn't show, doesn't mean she have not come in contact with HPV over the past 5-10 years. Now, can you develop high-risk HPV and high-grade lesion within a short period of time? And I've already shown you that it can take years for this to develop, and therefore, all of a sudden that she got this, there's no chance of specifically finding out where exactly she got the HPV virus. I will reassure her that no, her husband has not been unfaithful. Yes.
A woman's been married for 20 years. She had a normal one last time. Let's go fast forward. And then she comes back with a positive HPV DNA.
Yep.
And she hasn't had any other partners. She's been regularly tested in DNA. I'm talking about it.
Yes. The sensitivity is very high. So if someone's detected high-risk HPV, it's quite likely that she does have HPV virus in the system. So why has she been... if she's gone to any partner, then the likelihood is it will come from her only partner. But I suppose it doesn't mean it's a concurrent sexual contact. It could be something in the past that stayed dormant and regress and progress in the system. So if a couple swear they've only got each other, it's highly unlikely that she will show HPV PCR positive.
Because can he be carrying HPV?
From previous contact, yes.
Like for long term?
Correct.
And not pass it on to her
yes.
until recently?
Or she has it in the past and it didn't show up on her test unless you test HPV on her.
Yeah, Yeah.
So if she only partner is her husband, that's the only way that they can come from. It can't come from towels or showering in the swimming pool or anything like that. It has to be sexual.
It's possible that he's been carrying
Yes.
HIV all these years and
Yes.
just recently passed to her.
Or he has passed on to long time, is only showing on her test.
I haven't completed the third test. The
Oh, go on.
Question.
Okay.
What is the best line of treatment for sensitivity? And this lady, she has seen 2 specialists. Everyone has completely different opinion, and she wants to know which one is the best.
She's got SIN2 on her SIN3 on her pap smear. She would have been referred to.
HPV positive.
Will be referred to the gynecologist to perform a colposcopy and biopsy to confirm, and she will be suggested to do ablative therapy and then do the follow-up every 2 years after treatment. We may be a bit tight on time. I'll move on to the second part of the topic. If you guys got more questions, I'll hang around after this talk or in morning tea if you want to ask me questions. Huh? All right. Next one. Latest contraception. I'm sure you guys are well aware of the various contraception choices available. So this talk, I'm going to summarize for you about the sort of current contraception options. I know it says latest contraception. There's actually not a lot of new things available lately. So I'm just going to go through with you what are the options and what are the new findings on some contraceptive. How do we tailor oral contraception to our patients? What are the vascular risks associated with contraception? I'm going to throw you some case studies if we've got time to test you so that I can wake you guys up and say, okay, I've got this patient, what contraception I'm going to discuss with this patient. Here we go. So I expect you guys to memorize all this. Actually, you guys already know this. So the top ones are the more effective or reliable contraception, and the risk of failure is about 1 pregnancy per 100 women per year. The bottom ones are the less reliable ones, which equates to about 30 pregnancies per 100 women in 1 year. So the more reliable ones are the implants, IUCD, sterilization, vasectomy, of course. The one a little bit less than that, your injectables. I'm surprised to see that lactation's up there. But remember, lactation, you're talking about regular breastfeeding, not just, half an hour once a day sort of thing. Of course, it's the pills. Patches, I know that's on this diagram. I'd look for patches, being able to find patches, contraceptive patches in Australia. They are readily available in Canada and UK and some European countries. It is not available in Australia, but apparently you can buy them online. So it's interesting. I haven't had any experience prescribing this myself, but apparently it's a weekly patches, and you put it on the weekly for 3 weeks and 1 week off, and apparently have good incidence. As far as risk is concerned, it still probably have similar potential risks and side effects and complications as far as the combined pill regimen is concerned, the vaginal rings. I don't know about you guys' experience. I have not have a lot of takers on the ring as well. And of course, it's your barrier methods, condoms, diaphragms, etc. Now, let's talk about the progesterone-only pills. It's suitable for cases when estrogen is contraindicated or not desired. We know that the mini pill, progesterone-only pills, have got much lower progesterone compared to the combined pill. How does it work? It affects the endometrium, the cervical mucus. But we know that 40% of people on the mini pill will ovulate, and therefore we rely on the mini pill working on the endometrium and cervical mucus as contraceptive. It has to be taken at the same time daily. If they miss it by more than 2-3 hours, they have to use additional protection for at least 2 days until their pregnancy test. The progesterone-only pills, the typical people who are suitable or should use these are the breastfeeding mothers, if they're more than 35, who are smokers, the migraine sufferers, the severe ones with aura we're talking about. If they're got predisposition to venous thrombotic events, if they're diabetic, if they're obese, they're hypertensive, the progesterone-only pills is the way to go. What about the combined pill with the estrogen progesterone preparation? So how do we choose which one? There are about more than 50 pills available to choose from. We probably got a few that we commonly sort of use more and comfortable with. When you decide on which pill is the best for your patient, you decide on which estrogen, the dosage of estrogen, the progestogens, the choice of doses, your regimen, and also you want to look at the additional benefits of that particular combined pill on other areas as well. So therefore, when you choose the combined pill, you need to consider the choice of estrogen. And most pills contain ethinyl estradiol, and some have got mestranol, and you've got the newer ones when they contain estradiol. It's thought that the more natural estrogen offer people who can't tolerate the synthetic high-dose estrogen, they may have some benefit, but unfortunately, you don't know the true effect of the pill on the patient as far as side effects until you try them. I usually advise my patients that when you try a pill, they should try at least 2-3 months to get the full effect, because the initial side effect may subside as time goes by. As far as progestogens is concerned, there are different types of progestogens available. The ones that have been around for a long time are the norethistron and the levonorgestrel. They are less estrogen dominant. With the newer 3rd, 4th generation pills, they contain the more the estrogen dominant progestogens. Of course, they have different effects and side effect profile and benefits as well. What about the choice of doses? As far as ethinyl estradiol is concerned, there's the option of 20, 30, and 50. I must say I have yet need to see a case when they take 50 and they don't have severe side effect. I very seldom use the 50. But there are some people who tolerate it very well, and that's for people who require the higher dosage. As far as progestogen is concerned, there's some preparations with various doses for norethistron as well. Now, as far as our regimen is concerned, there's the monophasic and the quadriphasic pill. There's the 21-7 preparation, so with 21 tablets of the active pills and the 7 sugar pills. And of course, there are preparations with 24 active pills and 4 sugar pills. So these are the various regimens available. Of course, the other benefits are that sometimes, apart from contraceptive protection, the pill can be used for treatment of acne, PMTs, and heavy menstrual problem. How do we tailor our contraception to the individual's need? Of course, breastfeeding is reasonably straightforward. They go on the mini pill. As far as PCOS is concerned, the combined OCP is probably a very good option, even though they don't require contraception. And you probably want to choose the more estrogen-dominant pills, which are your 3rd, 4th generation newer pills. And it's probably better at controlling the acne and probably has better anti-androgenic effect as far as the hirsutism is concerned. Now, the pill has been thought to be the cause of weight gain in a lot of cases, and if it does occur, it's likely due to the increased appetite, the water retention properties, but there have been some studies that look at and quantify the weight gain, and some pills and some studies suggest that it actually does not cause weight gain. As far as breakthrough bleeding is concerned, if our patients are developing breakthrough bleeding on the pill, if they just first started, keep going and persevere for 2-3 months, but if it's persisting past that, or if it's a new pill or they've just changed it, then there is an option to increase the estrogen. There's an option to change the progestogens, and you can try them on the triphasic and the quadriphasic pills to counteract that problem. Now, the pill has been the center of attention recently when there has been studies, which is the EURES study, which is the European active standardized study in Europe, when they prospectively follow for 5 years, looking at 60,000 women, and there has been found to have a link between Yasmin, for example, comparing to the 1st, 2nd generations pill as far as thromboembolic events is concerned. So there has been a lot of hype around that time. So the question is, when people come for advice for the pill, we need to think to ourselves, what are the vascular risks to women who use contraception? And question 2 is, what contraception can I use for those people who are already at risk of thromboembolic events? So I'm going to tackle the first question to start with. What are the vascular risks to women who use contraceptive? So the risks include venous thromboembolism, which is your DVTs and your pulmonary embolus. There could be vascular risk arterial disease, which are your strokes and infarct, which is the risk of hypertension as well. So I'm going to talk about each in a second. Now, I was talking about the EURES study that I mentioned. It was getting a lot of media attention. Now, we need to explain to our patient that such study, it is probably more representing a class effect, meaning that you're looking at the relative risk of a particular condition over a broad, large population base. And therefore, even though statistically, number-wise, it does increase your relative risk, the exact risk to the patient is totally different from what is stated as far as relative risk is concerned. So we need to, as doctors, put it in perspective and explain to our patients that we need to put the interpretation of this study into perspective. Now, if you look at the risk of thromboembolic event, if someone's not on contraception, they are not pregnant, the risk of DVT, pulmonary embolus, annual risk per 100,000 women is about 5. If they use pill of the first, second generation, they do have slightly increased risk of thromboembolic event and will go up to 15 per 100,000. If they use the third, fourth generation pill, the risk is 25 per 100,000. So yes, it appears that it does increase. But compared to women who are pregnant, compared to women immediately in the postpartum period, you can see that the risk is actually significantly increased when they are pregnant or associated with pregnancy and delivery. What about the mortality? What about the fatal DVTs and pulmonary embolus? Just remember the background risk is sitting at about 0.6. By being on the pill, this is not specific type. It does slightly increase, but they increase it by 0.6 to 0.3 per 100,000. Just remember that with the background of death related to smoking, compared to 0.6, you're looking at about 167 for related to smoking, and the road death is about 8. So it is terribly important to put things in perspective. So therefore, for them to have reliable contraception, it does have its pros and cons and risks associated, but I suppose it is weighing against the risk of an unplanned pregnancy that you're comparing to. So, what do we advise our patient? This is very confusing enough as it is for us. As far as, should we use the pill as a contraception for people who may be potentially at risk? So we need to reassure our young, healthy patients that young, healthy women have a very low risk of DVT, pulmonary embolus risk on the pill anyway. Now, if they have existing medical complications such as obesity, smoker, family history of thromboembolic events, or they've got at risk of cardiovascular risks, then as providers, health providers, we need to assess their risk individually to see the pros and cons and the risk, what are the options, what do the patients want, etc., to tailor-make the best contraception advice for them. Just remember that the higher relative risk in the third, fourth generation pill are increased, but the absolute risk of the patient getting thromboembolic risk is small. It probably translated to added risk of 2 to 4 cases per 10,000 users. Bearing in mind that even though it sounds scary to use the third, fourth generation pills now because of the thromboembolic events, just remember that it has great advantage over management of their acne, hirsutism, water retention, bloating issues, and one need to balance the risks and the benefits of using a particular pill for a particular patient. So, I've just gone through the venous thromboembolic risk. What about the arterial risk with using the combined OCP for these patients? So the risks are, myocardial infarction, hemorrhagic stroke, and ischemic stroke. Now, it's been shown that the combined OCP is not the prime cause of most arterial events in pill users. AMH risks are actually increased in smokers. There's no increased risk of hemorrhagic stroke unless there are other risk factors in the patient, such as hypertension. And as far as the people with migraine and aura, OCP users have probably increased risk of ischemic stroke risks. So we need to be careful for those people who've got a high risk as far as putting them on the pill. What about hypertension and the pill? The pill probably lead to slight increase in blood pressure. However, the slight increase should still be within the normal intensive range. And less than 1% of the pill users will become clinically hypertensive, and maybe due to their underlying issue, family history, or their lifestyle. Now, this is the second scenario now. what are we going to do, or what are we going to advise our patients if they've got existing vascular risk? Who are these people that we need to be careful with? These are patients with hypertension, with previous thromboembolic disease, they've got migraine with aura, they've got varicose veins, they've got ischemic heart disease, valvular heart problems, smokers, increased age and obesity. These are the people we need to be careful with using the pill on them. Now, the options of contraception for these potential risky women, we can use non-hormonal preparations such as barrier method, copper T, IUCDs, or we can use hormonal preparations such as progesterone pills, Implanon, Mirena, combined pills, contraceptive ring. All right, time to wake up. No, I'm sure you're not sleeping. Go through some case studies so that we can see, okay, in real life, in practice, what we're going to do for these people. Case number 1. 32-year-old accountant come to see you. She's got a child. She was induced because she's got gestational hypertension. She's got ongoing blood pressure now. She's on Caterpillar for blood pressure management. She's gone back to work. She finished breastfeeding now. She wants contraception. She was on the pill before with no problems. Her BMI is 28. There's no history or family history of DVT pulmonary embolus. She got some spider veins in the legs. She had a bit of superficial thrombophlebitis during pregnancy. So, put your thinking cap on. What are the options available for her? Yep. Yes. Progesterone only, Depol, Implanon, Mirena. Combined pills still okay because just remember she had mild blood. She's got sort of the gestational hypertension. She's in a good BMI range, non-smoker, need reliable contraception because she can stay on the middle pill if she wants to. But sort of she may forget and things like that with work and things like that. So it is an option. So you can use the progesterone only, you can use it combined with care, choose your group. Advise her to continue to exercise, healthy lifestyle exercise. It's going to reduce your risk. You can use your copper IUCD, you can use a Mirena, you can use barrier. So that one's sort of easy. I've got more interesting ones coming up. Case B. 40-year-old teacher. She had 2 kids. One, they were born by emergency Caesars. She had an AMI, 6 weeks postnatally, and now she's got a stent in. She's on antiplatelet agents. Now she's got heavy periods. Mirena is my favorite one, if you ask me anyway. Yeah, no sex would be good, wouldn't it? No, we don't want the husband waiting for us in the car park. Progesterone contraception, Implanon, Mirena, sterilization. Should have 2 Caesars. Depot? Yes. Yes. All right, 30-year-old admin officer, Nali Paris. Just had a valve replacement. She's on warfarin. Well, the combined pill is out. Anything hormonal is out. IUD, potential foreign object in the uterus, potential infection risk for the heart valves, out. Sterilization and barrier method. You'd be brave to put a Mirena in. You'd be very brave. I would advise not. Risk of infection. Heart valves. What if you infect your valves? Implanon, hormonal. With your warfarin, thromboembolic risks.
During your
Heart at risk. So it's not absolute, but it'll be you'll be brave to do it.
sterilization, you use clips. That will be
Clips or self-injecting, doesn't matter, but it's going to be, yeah, then you have to move the well, yeah. But
if you use clips. That could be a source of infection as well.
no, but that's intra-op thing, so it's not ongoing risk, infection risk. Yeah? No. All right, 20-year-old medical student, migraine with aura. Without aura, sorry. Thank you for reading my slide. I can see you guys not sleeping now. All right, no other medical problems. Don't want to fall pregnant, absolutely. Her parents will kill her. Headache, investigated by a neurologist, all good BMI, no history. Busy lifestyle, can't remember stuff. You're a great fan of Dapple, aren't you? Yeah, Dapple's. Yeah. NuvaRing. What are you guys experience with NuvaRing? Do you have a lot of takers? No. Cost is actually not that much greater than the patches or the Marina is probably, the IUC is probably the cheapest, the Marina, but $30. Look, I think patients, they're willing to pay $80 a month for reliable contraception that they feel comfortable with, so it's actually not that bad. I think it's just a thought of the women insert tampon with no issues, but they're stressed about inserting the ring somehow. Anyway, decided already? All right, answer. Combined pill or ring, progesterone only, implanon and the depot, intrauterine contraception, barrier method, mini pill. Barrier method and mini pill because she's young, she's busy doing whatever, probably she'll forget. I've got 2 more cases. 28-year-old flight attendant has skiing injury overseas, flying back in crutches. She had developed DVT from her cast plaster. No prophylaxis in transit, that's very brave. Was using the pill until the incident. She's a non-smoker, family history is negative. She was screened for thrombophilia, negative. So she needs contraception now. She still recently got the DVT though, be careful. So she's still, yeah, so avoid estrogen. Avoid estrogen, use progesterone only while she's still within 3-6 months from her DVT diagnosis. Progesterone only, implanon depot, intrauterine contraception. Study F, last one, 38-year-old smoker, BMI of 38, which is majority of our patients, by the way. Para 4, all Caesars, don't want tubal ligation, sterilization is out. So you would try to avoid estrogen, multi-load. Multi-loads are not available anymore. You have to request copper T now. Yeah, yeah. Avoid estrogen, progesterone only, implanon depot, Marina, copper T, vasectomy. She doesn't want sterilization. Get the husband to do it. All right, I heard the bell, so I better go on my final slide. If all fails, give them this instruction. Thank you.
We have time for maybe one quick question. This lady at the back, I was waiting for them before.
Okay, if they complain of libido, how are we going to adjust the contraceptive pill? Overall, the basis of how the pill works is that it gives you exogenous synthetic estrogen to suppress your FSH as far as prevention of ovulation is concerned. So naturally, you expect the libido to go down. So naturally, the pill is not a great friend of reduced libido. So if they still want the pill and not use alternative method, hormonal method, then you probably go on the quadriphasic pills, the more natural estradiol one, hoping that it will be okay. But just remember, overall, when the libido goes down, it may not be the pill. Quite often, they just had the kids. They, longer time spending in their relationship. They're tired. They're getting older. Etc. So sometimes it probably ask a few questions, find out what else is happening, and you can advise them. But overall, if they're desperate about libido issue, you may have no choice but to stop the pill and use alternative methods. Yeah, and the last slide, that will fix it too. The libido, that's good for libido too, just no sex in the moment.
Sorry, regular bleeding and stuff like that. So we really should that. But if they bleed a lot, can we add a progesterone shot period?
If they're already they're using Implanon or Mirena, they're bleeding a lot. Well, we know that 20% of progesterone only, that the long-acting reversible progesterone preparations, 20% of people actually have disturbed or prolonged abnormal bleeding. You can try to rescue it by putting estrogen back in because they're progesterone only. Sometimes the patient will be in severe distress. They will no longer want to use it and use alternative method. But just before you actually start them, it's best not to use a method and then when they have trouble and to discontinue, you need to counsel them beforehand. Just let them know that, okay, the progesterone only preparations are reliable, and in terms of Depo or Implanon, you don't have to remember. Just remember, progesterone only preparations do disturb cycles, and 20% of people have undesirable heavy bleeding, and they need to almost accept that. Sorry, and then but the only thing regulate the cycle is the combined pill. So if you counsel them beforehand, then it's best to avoid getting into that situation. At least if it happens, you say, okay, it's just one of those things that can happen. I better stop talking.
We might just can we take this last question?
All right,
quickly?
Okay, go on.
What age you can use the contraception? Can you use it in menopause?
Can you,
And the contraception until the menopause.
in terms of if they're in menopausal age as well, but they still need contraception?
Up to menopause.
Up to
menopause.
not advisable to use it past age 45, the combined ones, but if you want to extend up to 48, 50, do it with care. Make sure you do your risk assessment.
And another question is, do you need any sort of a pap smear for the lesbians?
Do we do, if they have, no, okay, remove that. Yes, you need to screen them because they can still have HPV.
Please thank Dr. Tang. That was an excellent talk.